Hello, and thank you for the opportunity to present our work. We were interested in using machine learning to explore ways to make left ventricular ejection fraction a more accessible measurement. LVEF is a very useful clinical measurement, not only to risk stratify patients before surgery, but also to diagnose a variety of conditions, including congestive heart failure. Unfortunately, it's a resource-intensive measurement requiring certified sonographers, supervising cardiologists, who expertly trace the left ventricle at least 20 times per scan using volumetric software. Ultimately, since the resources of a cardiovascular laboratory aren't available particularly quickly in any setting and aren't available in a lot of rural or low-income areas, we were interested in using machine learning to predict abnormal left ventricular ejection fraction directly from ultrasound images to expedite and inform diagnosis and treatment in emergent or low-resource settings. EchoNet Dynamic is a database of 10,024 de-identified 4-chamber apical echocardiograms with expertly annotated left ventricular tracings at the end systolic and end diastolic frames. This produced an expert-level measurement of left ventricular ejection fraction that we could use to train and familiarize a model on how to make this prediction. Figure 1 illustrates the schematic of the data that we were provided from this source, which includes a continuous set of video frames of the left ventricle, followed by the expert tracings and a calculation of the ejection fraction. We went ahead and binarized the continuous ejection fraction measurement into being normal or abnormal. Our category for normal left ventricular ejection fraction was 55 to 70%. In order to develop models that can accurately categorize this ejection fraction measurement, we had to split up the data accordingly into training, validation, and test sets. In a 60% cut of this data, the model would train and learn to build characteristics in order to try to predict the outcome of ejection fraction, normal or abnormality. A 20% validation set following would then be exposed to the model to allow for tuning of hyperparameters once certain characteristics were identified. And once the model was finalized, overall performance was then tested using a 20% held at test set that the model had never seen prior. This was in order to ensure that the model performance was not inaccurately inflated by the fact that certain patients or cases might have already been seen. And again, to facilitate this sort of technology being performed at the bedside, we didn't require full video frames of an echocardiogram. Rather, we just extracted one end diastolic and one systolic frame from each patient. Table 1 illustrates the distribution of features between trained, validation, and test sets. You can see that we preserved the incidence of the abnormal EF patients throughout trained, test, and validations for about 23% prevalence. Then, using publicly available architectures for convolutional neural networks, we explored two methods of predicting abnormal EF. First, we explored intermediate segmentation, in which we used an convolutional neural network to actually predict what the tracing of the ejection of the left ventricle would look like, and then asked another model to try to predict based on those tracings whether the EF was normal or abnormal. This was called an intermediate segmentation step because we actually took the time to trace out the left ventricle using machine learning methods. The other method was a more direct method in which we simply fed in the raw echocardiogram images and asked the model to try to predict whether the EF was normal or abnormal. And so this is better explained in figure 2, which sort of illustrates the two pathways that we explored. Figure 3 shows how our machine learning models were able to actually segment out the left ventricle from the raw ultrasound. The overlap is best seen visually. On the right side, you have our actual model generated masks compared to the ground truth tracing performed by hand in the middle column. There was about an 86 to 88% overlap between the pixels of our segmentation versus experts, suggesting that already the proof of concept that this process can probably be automated and improved upon, even if we are in the setting of places with a cardiovascular laboratory. So while that finding was already really exciting, we then put our models to the test on the 20% out training set. Here, table 2 illustrates the performance of the best performing models, notably models without segmentation, in which just raw images were fed, were best performing. The best performing model specifically was VGG16, which is in the third row of table 2, with an accuracy of 85% and a specificity of 88%. Figure 3 contains precision recall and receiver operating characteristic curves, which measure the trade-offs of how much sensitivity and specificity you get as the incidence of the ejection fractions abnormality increases in your data set. It's notable here that our best performing mean precision was 78%, and our area under the receiver operating curve was 0.9 for our best performing model, BGG16, which ultimately suggests that there's very good performance in deploying this model. Figure 5 then illustrates a discriminant sub-analysis in which we tried to see which types of cases the model struggled the most on. So by separating out the true positive, true negative, false positive, and false negative patients as classified by the model, we could also see how the EF varied between the populations. The takeaway from figure 5 is that the model had the hardest time distinguishing patients with slightly low abnormal EF. So folks in the 40 to 50% range were most likely to be categorized as a false negative, yeah. So as we conclude, using two representative images from an echocardiogram, deep learning models can accurately identify abnormal EF with up to 88% specificity. The top performing model still had some difficulty distinguishing abnormal EF slightly below the 50% threshold, suggesting that there's still room to improve on this and build slightly more discriminant models. But overall, this technology demonstrates our ability to improve the accessibility and speed of EF measurements from bedside echocardiogram, which could apply to a lot of emergent or low resource settings like trauma bays, ambulances, really anywhere without a cardiovascular laboratory.